In a separate video, we'll be looking at platelets and the nomenclature of the procoagulants. So today the outline of our discourse today will include the hemostasis system, looking basically at the hemostasis system, which is broadly divided into primary, secondary, and the fibrinolytic system. We are going to look into the mechanisms of hemostatic system, the plasma-based in vitro coagulation, which is also subdivided into extrinsic, intrinsic, the contact pathway, and the common pathway. Then the cell-based in vivo, the physiologic coagulation, which is also grouped into initiation, propagation, amplification, and clot formation. So at the end of this discourse, we'll be able to exhibit a comprehensive knowledge and critical comprehension of normal and pathological processes in hemostasis and thrombosis for each coagulation complex. That's the extrinsic, the intrinsic, the prothrombinase, be able to identify the serine protease, be able to identify the serine protease and the cofactor forming the complex, the type of cell involved, and the substrate activated. We'll also be able to list the factors in order of reaction in the plasma-based extrinsic, intrinsic, and common pathways. You should also be able to describe the cell-based in vivo coagulation process and the role of tissue factor-bearing cells and platelets. These are the objectives, what we are supposed to know at the end of the lecture. So when you look at the coagulation pathway, coagulation systems, it seems to be incomprehensible and needlessly complex. As the various systems and pathways are developed, it's discovered to be an elegant series of serine processes that amplify a small stimulus into an effective defense. Coagulation is controlled by a series of mechanisms, and its products are ultimately resolved in seconds in a well-contained metabolic process called fibrinolysis. So during an arterial wall damage, I was trying to lay some backgrounds before we go into the mechanisms of coagulation. During the process of, if an arterial wall is damaged, it exposes the subendothelial collagen and tissue factor, triggering platelet adhesion and aggregation and activating the coagulation mechanisms. Okay, injured endothelial cells releases phospholipids and von Willebrand factor. The von Willebrand factor attaches to the subendothelial collagen and binds platelets. The thrombotic and end product of coagulation in capillaries, arterioles, and arteries is nicknamed the white clot, consisting mainly of platelets and von Willebrand factor. The white clot may occlude arterioles and arteries, causing myocardial infarction, stroke, or peripheral artery disease. In the case of damage to the venous wall, in the veins and the venous, the bulky red clot consists of platelets and von Willebrand factor, fibrin, and red blood cell. Although this is a protective mechanism, the red clot may occlude vessels, causing venous thromboembolic disease. That's the VTE we all know about. So the hemostatic mechanism is broadly divided, as we said in the previous slide, now slide number 1, that generally the coagulation mechanism is divided broadly into the primary, secondary, fibrinolytic system. So we're going to look at primary hemostasis before we go into the secondary hemostasis. So during the course of primary hemostasis, When there is damage to either the artery or the veins, as we have said in the last slide, primary hemostasis consists of 4 steps. The first step in primary hemostasis is the transient constriction. The transient constriction of the damaged vessel wall mediated by reflex neural stimulation and endothelin release from endothelial cells. The second step included the platelet adhesion to surface of disrupted vessels. Von Willebrand factor binds exposed subendothelial collagen. Okay? The von Willebrand factor that's binding is derived from the Weber palette bodies of endothelial cells and the alpha granules of platelets. Then platelets bind VWF using the glycoprotein 1B receptor. The next step in primary hemostasis is platelet degranulation. Then degranulation, the adhesion of platelets to the exposed endothelial cells induces shape change in platelets. And this shape change activates platelets to release granules. The granules release multiple mediators such as ADP from the dense granules, and this ADP released from the dense granules of the platelet promotes exposure of another receptor on the platelet, the glycoprotein 2B3A receptor on platelets. Also, thromboxane A2 is being also released, and it promotes platelets aggregation. So that in the next step, step 4 of primary hemostasis, we have platelet aggregation. And in platelet aggregation at the site of injury, platelet aggregates at the site of injury via the glycoprotein 2B3A complex using fibrinogen as a linking molecule. This results in the formation of platelet block. As you can see from the diagram representing what we have already stated, a hemostatic block formation, you can see if there's injury, response to injury, the vessel constriction, that is the first um, response of the blood vessels, the constriction, the formation of unstable platelet block, which signals the end of the primary hemostasis. The primary hemostasis consists of platelet adhesion, platelet aggregation, the process we have described in the last slide. Then before it goes down to the secondary hemostasis, stabilization of the plug with fibrin. That is what happens in the secondary uh, phase of coagulation. Then dissolution of the clots and vessel wall repair, as we shall see as we go on. So trying to use a picture to depict what we have stated about the primary hemostasis during the course of damage to endothelial cells. Can see in this diagram endothelial cells, the vessel wall being damaged, exposing the endothelial cells. Okay, and when that happens, the platelets von Willebrand factor are released from the endothelial cells, and this von Willebrand factor binds platelets, which we call platelet adhesion. This von Willebrand factor binds platelet with their glycoprotein 1B, okay, that is platelet adhesion, or the collagen also being released from the subendothelial cells can bind also platelets directly. Those are the process of platelet adhesion. When that adhesion, we say, causes a shape change and degranulation by platelet, releasing ADP and thromboxane A2. Okay, the ADP released enhances the platelets to express another receptor which we call the glycoprotein 2B3A complex. Okay, and also the thromboxane that encourages platelets aggregation. So platelet aggregation takes place, you can see it. Okay, platelets and platelets combining together, aggregating using the glycoprotein 2B3A complex, using fibrinogen, which is already in the blood, as a linking molecule to that. So that is what we can see in primary hemostasis. Primary hemostasis basically ensures the formation of platelet plug, and these platelet plug are unstable, that if they are not acted upon by the secondary hemostasis, they can easily be carried away as as the blood flows through the system. They are unstable plugs, so they need to be stabilized. The fibrinogen need to be converted to fibrin to make it more stable. But the primary hemostasis ends at this phase of just forming a platelet plug. And we have said that the platelet plug that is formed is basically unstable. So we need to go further. Okay. So the secondary hemostasis will now come about with secondary hemostasis. Secondary hemostasis in all its entirety, what it's trying to do is to convert that fibrinogen that is used as a linking molecule for the platelets, to convert it to fibrin. That is the whole process of secondary hemostasis. That is what the secondary hemostasis is trying to achieve. The primary hemostasis ends at the point of generating unstable platelet plug. This unstable platelet plug has to be stabilized, and this phase occurs in the secondary hemostasis. So these secondary hemostasis are also divided into the intrinsic, extrinsic pathway, the waterfall cascade, the contact activation pathway, which includes this. Then we have the cell-based model of coagulations. It's just trying to tell us that to describe the secondary hemostasis, either we use the cell-based model, that is the waterfall cascade, the classic pathway we all know, or we use the cell-based model to describe the secondary hemostasis. The coagulation cascade involves a complex set of protease reactions involving different proteins. The final result of this reaction is to convert fibrinogen, a soluble protein, to insoluble strands of fibrin. Together with platelets, the fibrin strands forms a stable blood clot. Okay. For years, the coagulation cascade was conceptualized as having two distinct points of initiation, labeled the extrinsic and intrinsic pathway. But over time, however, it has become clear that these pathways do not function in the body as parallel independent systems. The observation that the tissue factor 7 complex activates factors in both systems suggests that they are linked. This discovery, combined with an evolving understanding of the role of different cells, in particular platelets, has led to a cell-based model of coagulation. So we are going to look at it one by one. Okay. Okay. So we're going to start with the plasma coagulation cascade, looking at it generally. Okay. In the past, we have seen that two coagulation pathways were described, both of which activate factor 10 at the start of a common pathway leading to thrombin generation. Okay. The pathways were characterized as cascades, in that as one enzyme becomes activated, it in turn activates the next enzyme. Okay. Most coagulation experts identified the activation of factor 12 as the primary step in coagulation, because this factor could be found in blood, whereas tissue factor could not be found in blood. Consequently, the reaction system that begins with factor 12 and culminates in fibrin polymerization has been called the intrinsic system. In the intrinsic system, or the intrinsic pathway, formation of tissue factor 7 has since proven to be the primary in vivo initiation and mechanism for coagulation. That's the extrinsic pathway. But because tissue factor is not present in the blood, the tissue factor pathway has been called the extrinsic system. These are the basics where they give the name to this pathway. Okay. The two pathways have a common factor 10, factor 5, prothrombin, and fibrinogen. This portion of the coagulation pathway is often called the common pathway because it is common to both the intrinsic and the extrinsic pathway. So we now know the reason why this pathway is given the intrinsic name, the other one is given the extrinsic name, and then the common pathway, because all of them culminates and comes down to the common pathway. This designation of intrinsic, extrinsic, and common pathway are used extensively to interpret in vitro laboratory testing and to identify factor deficiencies. However, they do not adequately describe the complex interdependent reaction that occur in vivo. They are used for interpreting laboratory tests for the benefit of understanding the process and procedures and how to monitor some of these factors and what assay you can use to monitor each of the factors. So for convenience in laboratory diagnostics and investigations, the coagulation system, plasma-based coagulation cascade system, were subdivided into intrinsic, extrinsic pathways for a better, clearer understanding. So, um, so as we've seen in this figure 1, it's showing us an overview of the whole plasma-based coagulation system. The coagulation systems, clotting usually begins when coagulation factor 7, okay, coagulation factor 7 is exposed to tissue factor and becomes activated. Then the activated factor 7 then cleaves factor 10, which becomes activated factor 10 and binds factor 5 in the presence of ionic calcium and phosphatidylserine serine from platelets membrane. Phosphatidylserine, PS, from now, we'll be calling it PS from now, and it's coming from the platelet membrane. Then this complex of factor 10 and the phosphatidylserine from platelet cleaves thrombin to form activated thrombin. Okay, that's factor 2. Then the activated factor 2, the thrombin, now cleaves fibrinogen to form fibrin. Okay, the thrombin, activated thrombin, also activates factor 11. It also activates factor 11, which activates factor 9, and then the activated factor 9 binds factor 8 in the presence of ionic calcium and PS that comes from platelets membrane. This complex also cleaves and activates factor 10 also. Okay, thrombin also cleaves factor 5 and factor 8. Finally, factor 12, prekallikrein, and high molecular weight kininogen are contact factors that trigger in vitro clotting in the presence of a negatively charged particle by cleaving factor 11. Okay, so that is the general overview of the plasma-based, the classic pathway of coagulation, the cascade of plasma-based coagulation pathways and overview. So we are going to we have said that the coagulation mechanism is divided into the extrinsic, common, intrinsic, and the contact pathway. And we have said that these divisions into pathway are used extensively to interpret in vitro laboratory testing and to identify factor deficiencies. However, they do not adequately describe the complex interdependent reaction that occur in vivo. So we will now examine this system one by one. Okay, the extrinsic pathway. Okay, when the endothelial cell is damaged, as we have said earlier, the tissue factor on the subendothelial fibroblasts and smooth muscle cells cleaves and activates factor 7, okay, which binds tissue factor in the presence of PS and ionic calcium. The complex cleaves factor 10 to form an active serine protease, activated factor 10. The active factor 10 goes on to activate the common pathway. This is what happens on the extrinsic pathway. The activated factor 10 will now go on to activate the common pathway. But there is another pathway, alternate pathway of this extrinsic um, coagulation mechanism we are going to look at. There's an alternative extrinsic pathway in which the tissue factor and factor 7 complex, they also cleave factor 9. They also activate factor 9. And when they activate factor 9, the active factor 9 will now bind to stabilizing cofactor 8 with calcium, ionic calcium and PS. Okay? That's another pathway by which the tissue factor can participate. Another alternate pathway for the tissue factor, factor 7. Okay, it can activate, tissue factor can activate factor 7, can also activate the factor 9. Okay, so it's an alternate pathway for the extrinsic coagulation mechanism. Oh, sorry. Okay, so we now go to the common pathway. The common pathway, which is common to both the extrinsic and the intrinsic coagulation complex. Okay, so the common pathway, when X is cleaved by factor 7 or factor 9, either the classical extrinsic pathway or the alternate, coming from the alternate pathway of the extrinsic system, it binds factor 5 with ionic calcium and PS to act as a serine protease and cleaves prothrombin, forming the serine protease thrombin. Then the thrombin then cleaves fibrinogen, forming fibrin. Thrombin also activates factor 13, forming the transglutaminase activated factor 13, which is a transglutaminase that acts upon the fibrin and forms stabilized cross-linked fibrin, as you can see in the diagram on the common pathway. As you can see in the diagram, the pathway for the activation of factor 10 and that of thrombin, and also activation of factor 13 and the conversion of fibrinogen to fibrin and the cross-linking of this fibrin molecule by the activated factor 13. So that is the common pathway, and this common pathway is common to both the extrinsic and the intrinsic system. As we have described the extrinsic system coming from tissue factor, factor 7, the tissue factor activating factor 7, or coming from the alternate pathway of the extrinsic by which it activates factor 9, or it culminates to this common pathway resulting in the formation of fibrinogen, in the conversion of fibrinogen that was used as a linking molecule in the primary hemostasis. The fibrinogen that is being converted to fibrin is the one that was used as a linking molecule. Remember, in the primary hemostasis, the conversion of that fibrinogen to fibrin results in formation of a stable clot. Then factor 13 is also used to form a cross-link for this fibrin molecule. So we're going to look at the intrinsic pathway. We have said that it is called the intrinsic pathway, or call it the intrinsic pathway. It's an additional thrombin feedback loop in which thrombin cleaves factor 11. Okay, so from this diagram, we can see that activated factor 11 is a serine protease that cleaves factor 9. Okay, factor thrombin activates factor 11, which in turn activates or cleaves factor 9, which binds cofactor 8, as you can see from the diagram. The complex cleaves the complex cleaves the complex cleaves the complex cleaves and activates factor 10, which continues through the common pathway, which continues through the common pathway. Okay, which continues through the common pathway. So as we can see in the diagram, the intrinsic pathway, as we can see from this diagram. Okay, now we are going to describe another system pathway, which we call the in vitro contact activation, because we now know that the factors we call the contact factors, the factor 12, prekallikrein, and high molecular weight kininogen do not play a significant role in vivo coagulation with trauma type injuries, although their deficiency prolonged the in vitro laboratory tests of the intrinsic pathway, in particular the APTT. Okay, we already know that fact has been established, that these contact factors 12, prekallikrein, and high molecular weight kininogen do not play significant role in trauma type in vivo coagulation. Okay, right. Although their deficiency results in the prolongation of APTT. These are facts that have been known. So the contact activation is an in vitro phenomenon in which factor 12 is activated in the presence of negatively charged surface like the silica, kaolin, or silicate, etc. But this is stabilized by high molecular weight kininogen. Activated factor 12 cleaves factor 11, and coagulation proceeds as described before. In the process, prekallikrein becomes cleaved, and a serine protease kallikrein bypasses factor 11 and cleaves factor 9 directly, as we can see in this diagram. Okay, in the process, this is cleaved in the process of being activated by negatively charged surfaces, stabilized by high molecular weight kininogen, prekallikrein cleaving, activating factor 12 and all that. In the process, prekallikrein is also cleaved on its own, and it goes ahead to activate factor 9, okay, directly. The kallikrein also triggers the inflammatory kinin system, creating a link with inflammation. So this is the pathway that describes the contact activation, the contact activation pathway, the contact factors. the contact factors. Although contact activation is predominantly an in vitro phenomenon, okay, the negatively charged surfaces of prostheses such as mechanical heart valve, stents, and left arterial appendage implants may trigger an in vitro coagulation process. Okay, so that is the contact activation system of the body. The contact factors: factor 12, high molecular weight kininogen, kallikrein. These are the contact pathway of the body. Although they don't play significant role in vivo trauma coagulation injuries, remember their deficiency can result to the prolongation of APTT. So that if you're running laboratory assays and APTT are prolonged and the patient is not manifesting any clinical significant coagulation symptoms, you think the contact pathway and try to analyze what will be the next line of action. So that is the clinical significance of this contact activation pathway. So we've said that as it flows from the primary hemostasis, we're able to generate the platelet plug. This platelet plug, we say they are unstable. They can easily be swept away, flushed away with the flowing blood in the vessels. Okay, and that these platelet plugs are formed by platelets that used fibrinogen as linking molecule. And also we have seen the process using the secondary hemostasis systems, secondary hemostatic mechanisms, where this fibrinogen are being converted into fibrin. Okay, so in the process of converting the fibrinogen into fibrin, we say that the thrombin cleaves the fibrinogen. And this slide is a diagram showing us the domains of the fibrinogen molecules and the sites of cleavage of the fibrinogen molecules by the thrombin. The fibrinogen is like a mirror image diagram. Each half of it consists of the alpha, as you can see in the diagram, the beta and the gamma chains joined by disulfide bonds. And each molecule of fibrinogen has 3 domains. It has 2D domains, the carboxylene molecule, and 1E domain, the central large portion, which is the central large portion of the molecule. And we have said that thrombin cleaves the fragments named the fibrinopeptides A and B, that is the sites of the cleavage, from the amino termini of the alpha and beta chains in the E domain, leaving behind sticky ends. These sticky ends are the ends that will polymerize with neighboring fibrinogen molecules. Fibrin formation, okay? So that's with the event of thrombin cleaving fibrinogen, we have fibrin being formed with that process. So fibrin formation, okay, as we illustrated, as you can see in this diagram, as illustrated in the previous slides, we've said that the thrombin cleaves fibrinogen, which circulates briefly as fibrin monomer, but soon polymerizes to form a loose clot called the fibrin polymer. Meanwhile, thrombin cleaves factor 13. Okay, thrombin cleaves factor 13. Factor 13 catalyzes the cross-linking of fibrin polymer gamma chains, making glutamine lysine covalent cross-linked or stabilized fibrin polymer, the key substance of the clots. So after thrombin have cleaved the fibrinogen, we have factor 13, we catalyze the cross-linking of this fibrin polymer, the gamma chains of the polymer, making glutamine lysine covalent, cross-linked, stabilizing the fibrin formed. So that ends the process of primary hemostasis, secondary hemostasis, and fibrin formation. Okay, we have looked at the process of cell-based, plasma-based coagulation system mechanism. We looked at the plasma-based coagulation mechanism, and we've stated some things. We are going to look at what are the value, what is the value, what are the advantage, okay, the virtue of this plasma coagulation system. We've looked only on the plasma coagulation system. We feel that the plasma coagulation system models coagulation as a series of amplifying proteolytic reactions. Each protease cleaves and activates the subsequent substrate zymogen in the series. The system also recognizes the participation of platelet and ionic phospholipids, predominantly the phosphatidylserine, the PS. And the plasma coagulation model is also essential assembly site for tinase and prothrombinase. It also models the PT and APTT as corresponding to the extrinsic and the intrinsic pathways. So these are some of the concepts of the plasma coagulation pathways. But this plasma coagulation pathway also has its limitation. Its limitation in the sense that there are some facts of the coagulation system. There are some understanding of blood coagulation that are not explainable using the plasma-based coagulation system. For example, the fact that if there is a separate, because the plasma-based coagulation system puts the coagulation cascade extrinsic, intrinsic pathway. There's a question is this: if there is a separate tissue factor pathway, why doesn't factor 7 tissue factor activate enough factor 10 to compensate for lack of factor 8 or factor 9 in hemophilia? Okay, so because the factor 8, factor 9 hemophilia is coming from the intrinsic pathway of the coagulation system. Now, as the way the plasma coagulation mechanism depicts or shows the coagulation as per extrinsic and intrinsic, okay, if there's a problem in one arm of the coagulation pathway, the other arm should be able to, okay, cushion the effect. But we find out that it doesn't happen that way. For example, taking classical example of the hemophilia patients, where you will see that either they are lacking factor 8 in hemophilia A or factor 9 in hemophilia B. Okay, since the tissue factor 7 pathway are intact, okay, why can't it now generate enough factor 10 to continue the coagulation pathway? It does not. And the patient with hemophilia are predisposed to hemorrhages. Okay, so that is a deficiency, or trying to draw a line in the coagulation pathway that intrinsic may not really show the full picture of what is happening. Also, we're so asking if factor 8 or factor 7 deficiency both causes severe bleeding as in hemophilia A or B, why is factor 11 deficiency bleeding mild and variable? Okay, why no fibrin generation when the platelet count is less than 10,000? Why does aspirin reduce thrombin formation? So these are some of the questions we are not able to explain using the plasma-based coagulation pathway. Okay, so these questions are left hanging and led to the concept of trying to explain coagulation pathway using the cell-based model. And in our next lecture, we'll be looking at this cell-based model of coagulation. Thank you very much for your attention.